Okay, so I was a bit lofty in my hope that I could finish this up in one more presentation. So I will finish this up in one more after this one. When we're thinking about common congenital anomalies, there are a few listed out on here. When you're talking about congenital anomalies, they could be cardiovascular, it could be related to the neural tube defects, GI, musculoskeletal, GU, and metabolic anomalies. So, as far as nursing interventions, and we're thinking about genetics and the fetal environment, really a lot of the defects go back to what the embryo was exposed to, the use of certain types of medications, uncontrolled diabetes, maternal body heat exposure, febrile illnesses, viral illnesses, lower socioeconomic status, just because we don't see those women coming in and getting prenatal help. So primary and secondary neural tube defects, the ones that we're going to talk about, we will specifically take a look at each one of them, primary as well as secondary. So when you are thinking about the primary, those are going to be the myelomeningeal, the encephalocele and ancephaly that will be on the next slide. And then secondary will be just meningeal seals and sacral agenesis or dysgenesis. So when you're looking at an encephalocele, that is going to be a herniation of the brain through the meninges of a skull defect. So this top picture where you see that the brains have are protruding outside of the skull. You can use surgical repair for shunting to help relieve some of that hydrocephalus, but they will obviously have some type of cognitive defect, even if they are able to go in and surgically repair that. Oftentimes what we're going to see is fetal. And then when you're looking at anencephaly, that's just absence of the brain. And the bottom picture is an infant with encephaly, and that is going to be incompatible with life. So what you will see is fetal death once that baby has been born. Oftentimes women will choose to end pregnancies, or if that is against their religious or cultural beliefs, they'll have the baby and they will have them in any type of center because it's not going to be compatible with life. Then spina bifida, there's different types of spina bifida. So this one is an occulta, and as you can see, it's just sort of hidden underneath the skin. So it's just a mild malformation in that posterior portion of the lamens. And so what happens is with the occulta, the spinal cord or meninges don't herniate or protrude. So what you might see in this area, rather than just this bump, is maybe an increased hair. They might have a birthmark, something like that. With spina bifida, you can see the meningeal or the myelomeningeal, and that's just looking at, and I'm going to click to the next slide just to show you a picture. So when you're looking at the meningeal and the myelomeningeal, you can see the differences in how far the protrusion of the spinal cord is. So when you're looking at just a meningeal, that's just going to be herniation of the meninges at the site of where that defect has occurred in the vertebral column. Usually it's covered with skin. When you're looking at the myelomeningeal, that's going to be our worst case scenario, and that's where we see herniation of the meninges and then also the spinal cord. Oftentimes there is a defect, and it can be with or without skin. So the thing you need to be aware of as a nurse is that sac can tear very easily, and then our baby's going to lose their cerebral spinal fluid. Also a great entry for infection. These babies with the meningeal, myelomeningeal, oftentimes we're going to see cesarean deliveries so that we don't risk rupturing that sac. And then if you are working in this, you want to make sure that this baby is also in the prone position. And then we would like to keep that area covered with a sterile, moist, non-adherent dressing. And then just remember to keep that moist. So thinking about safety is going to be importance of not tearing that sac, keeping that warm and moist until they're able to surgically then repair that myelomeningeal or the meningeal. Hydrocephalus then is going to be excessive cerebral spinal fluid in the brain. And when we talk about hydrocephalus, really treatment of that is going to be medical management with a surgical shunt placed. And what they do is they put in a shunt ventriculoperitoneal shunt, and that just drains the ventricle right into the perineum. It allows for that excessive cerebral spinal fluid to then just be emptied into the peritoneal cavity. Things that you see, signs and symptoms, hopefully you've covered in intracranial regulation and advanced concepts, but we see an increasing head circumference, so that's why it's important to do an initial measuring of head circumference and then serial measurements if you're noticing that something is differing. Widening of the sutures, so looking at their skull and looking at what the suture lines are, and then tense or bulging fontanelles. So normally those fontanelles should be soft, not sunken in and not bulging. You can see vomiting, irritability, shrill cry, and those things are all related to that increased intracranial pressure. So our goal is to reduce that pressure until this ventriculoperitoneal shunt can be put in. So elevating the head of that crib, keeping the noise down, keeping the environment calm, reposition the baby only about every 4 hours, because the more we mess and adjust with them, that causes increased pressure to their brain. So a nice, quiet, calm environment is going to be important. Doing those serial head circumferences and neurologic checks, and then reinforce preoperative and postoperative teaching to those patients once that shunt has been in place. Congenital heart defects, really risk factors are going to be related to the torch infections, as well as use of different types of medications, lots of different things, obesity, family history of defects. And the etiology can be chromosomal, or it could be genetic. It could be a combination of the both. It just depends on the situation. So the signs and symptoms range in their severity. So with a cardiac, if it's involving cardiac congenital heart defect, you're going to see cyanosis, pale modeling, bradycardia, those types of things. And if it's on the pulmonary side, then we're going to see some tachypnea, dyspnea. And so what we want to do is report abnormal findings to our physicians, and then administer the nitrous oxide, again, to decrease that pulmonary hypertension, prevent crying if at all possible, so using sucrose and a pacifier, anything to try to help keep the baby calm. And this photo comes out of your book, and there's just different defects that are most common, and the ventricular septal defects are really the most common. You can see here with a patent foramen ovale, coarctation of the aorta, tetralogy of Fallot, and the patent ductus arteriosus. So really these are what are going to be very common for you to run into, if you should ever run into them, and you would decide to work in newborn intensive care. When we're talking about cyanotic and acyanotic heart defects, you need to be aware of which ones cause cyanosis and which one will be acyanosis. So your cyanotic then are going to be the tetralogy of Fallot, or the transposition of the great vessels, coarctation of the artery, those types of things that are involving those great vessels of the heart. And then the acyanotic are going to be like your ventricular septal defects, your ASD, patent ductus arteriosus, just different things in different locations of the heart. The next few slides, we're going to just take a peek at the congenital birth defects, and these are found in your book. I did delete some of them as far as clubfoot and a couple of other ones that we have already discussed previously on the presentations. So when you think cleft lip, cleft palate, these are all going to be able to be diagnosed on ultrasound. When we think of cleft lip and cleft palate, think back to the graph that you were given, and it shows when fetal and embryonic development occur. And so when we're thinking of these things, they can be caused by genetic or environmental exposure, environmental factors. So when we're thinking cleft lip and palate, the management is going to be surgical management, but until surgery can be performed, we want to make sure that we're using special bottles, special feeding techniques, and minimizing the concerns about aspiration and also the stress on the parents. Because if you have a cleft lip and palate that are able to be seen just by looking at the infant, they're not going to look very pleasant. And so we want to ensure to our parents that, once the surgeries are completed, essentially that newborn baby is going to look really great. But correction can't take place until 6 to 12 weeks of life. So we have to figure out how we're going to get these parents to feel comfortable and confident and empowered and able to take this baby home and feed them and continue to have good weight gain and things such as that. Esophageal atresia and tracheoesophageal fistulas. The esophageal atresia is just simply the esophagus ending in a blind pouch. So there's really not a stomach per se. And then your tracheoesophageal fistula is just an abnormal connection that occurs between the esophagus and the trachea, which you should know from A&P is not the way we like things to go. So when we're looking at these types of things, they can be surgically repaired. The initial nursing interventions are going to be obviously airway, so supine with the head of the bed elevated, and then an orogastric tube to low intermittent suction to keep things out of the pocket and out of the fistula going into the trachea. And then again, it's all going back to that 101 of thermoregulation, fluid intake, acid-base balance, making sure that we have respiratory and ventilatory support and prevent respiratory depression. An omphalmocele is a defect out of the umbilical ring, and it can be varying amounts. So you might see a small portion of abdominal organs herniated out, or maybe you'll see the entire contents herniated out. A lot of times we see the omphalocele with many of the trisomies, and what we do or what occurs is that it is a surgical procedure to correct and repair that hernia. So what we will do until that can occur is use a plastic bag to prevent dehydration and water loss. We're going to maintain their thermal regulation. We want to prevent any contamination onto those organs because otherwise that would cause infection. A side lying position is good, especially if you have a large amount of contents outside of the abdominal wall, and then just laying a baby blanket underneath them to keep it supported and kind of at the same level as the baby. We will cover that in a sterile, moistened saline gauze as well, and then wrap that up with the plastic wrap. We'll probably have to end up using nitrous oxide once again to prevent pulmonary hypertension and vasodilation. We'll also use antibiotics, and then always paying attention to our fluid and electrolyte imbalance because dehydration from insensible water loss can be common. Gastroischemias is herniation of the bowel through a defect in the abdominal wall. With gastroischemias, there's no membrane covering the viscera. There's really not any other anomalies or defects associated with gastrosthesia, so the treatment therefore is just the same as the treatment for the omphalocele. An imperforate anus is a disorder that obviously involves the anal area or rectum, can oftentimes have some genital uro involvement. We see the imperforate anus more common in males than females. Oftentimes when this occurs, we have to the baby has to have a colostomy placed for a period of time, or can be permanent placement. So surgery is really going to be the best option for this one. When we are talking about hypospadias and epispadias, what you will see is that there's an abnormality to the penis, and the urinary meatus in the hypospadias is located along the ventral surface of the penis, the scrotum or perineum, and with the epispadias, the urethral opening is on the dorsal surface of the penis. We have seen this in a couple of clinical rotations that I've had students in, and oftentimes what will occur is that the infant will see a urologist, and they will set up if it needs to be surgically repaired, if it's a large defect, then it will require surgical repair, and then we're going to wait on doing circumcision until this area can be repaired. So we will finish up hopefully with the next presentation. If you have questions, please don't hesitate to ask, and thanks for your listening skills.